All right, let's get started here. So my task is prosthetic valve, or no, actually just endocarditis, CT, MRI, echo. I'll cut to the chase. It's all echo. There's no role for MRI. CT is very small. And I've given that talk, I think I've been here now 10 years, and I've given it about 1,000 times. So we're going to change gears a little bit. This is actually a talk I gave at the Southwest Valve Summit. It's a little more updated. It's a little more focused. And then if we get through this quickly, I have another short talk that I gave at ASC last week, which I'd like to share with some of you. All right, so what is a vegetation? That's really the first question. You hear me talk a lot about vegetation. We often call them wigglers. That is a fundamental feature of a vegetation, is the mobility. So this one meets all the criteria of a vegetation by way of example, okay? So it's bulky, perhaps. It doesn't have a uniform dimension. It's bulky at the bottom. It's linear at the top. Important to note, on a native valve, it's on the flow surface. So the atrial side of the mitral valve, the LVOT side of an aortic valve, the atrial side of a tricuspid valve. And the reason being, it's the flow surface tends to take the endothelial beating and the disruption of the endothelium. That is the first process in developing a vegetation. So it's useful when you're evaluating is something a vegetation to think about, is it on the flow surface? But it is imperfect, particularly when you start to involve prosthetic valves. It falls apart on a prosthetic valve. But on a native valve, it's a reasonable feature to look at. So we all know the Duke criteria. This is really a research tool. We don't use this clinically, but the point of it is what defines endocarditis based on the Duke criteria. One of the ones is you can have two major. This stuff doesn't really matter. You can memorize that if you want to. But the issue is, vegetation, mobile mass on an echocardiogram is a major criteria. So that's why we do echo so much. That's the point that I made a moment ago. This is this little graphic showing that tends to be where the endothelium is beat up and where the vegetations begin. This is the pathogenesis that's important to sort of at least understand. It's not a pure mass of bacteria. It tends to be some damage that starts, and that damage, that's why you rarely get endocarditis on a completely normal native valve. It just doesn't happen because the flow surface is so smooth, bacteria don't adhere to it. So it can be a congenitally abnormal valve, like a bicuspid valve. It can be any prosthetic material, which by definition is not normal. It doesn't have normal flow profiles. It can be damaged in some capacity, like a prolapse valve, so something's abnormal. So it's not impossible to get normal native valve endocarditis, but it is uncommon. So usually there's some damage or disruption that starts, you get some inflammation, then you have this sort of cycle of sort of colonization with bacteria, you start to get a mass, then you get these layers of fibrin and platelet deposition, and this just keeps going. So this is how a mass grows. It's not just the pure accumulation of bacterial deposits. There's fibrin, there's other stuff. So it gets a little confusing when, conceivably a mass might respond a little bit to anticoagulation, which gets confusing when you're trying to differentiate the two. After some series of growth and enlargement of the mass, depending on what the bacteria is, it may become embolic. The embolic phenomenon has not been shown to be bacteria dependent, but the invasiveness and the destruction has been shown to be bacteria dependent. For things like Staph aureus, are very destructive locally. So this is sort of what a vegetation looks like in histology. It's basically fibrin and platelets. That's the pink stuff. And the small little bits of blue and purple are actual bacteria. So important to recognize that. Whole lot of risk factors. We're not going to go through all of that. Any form of immunocompromise is a risk factor. Poor teeth, hygiene is an obvious one. So with that in mind, have a look at this guy and see what you think. So this is clearly an abnormal mitral valve. If you look closely, there's on the flow surface of the aortic valve, there's even a little wiggler here. It probably doesn't project very well, probably a bit too bright, but it's clear on the laptop. This tomahawk thing, the antemitral leaflet, looks like an axe. And you've got mobile elements down here. So this is unusual because it has a lot of bulk and not a lot of mobility. So I show you this because there are no absolute rules with endocarditis. So this doesn't have the mobility you'll often see. But the reason this one is abnormal is because it's fungus. And fungal endocarditis can actually behave a little differently. You can get very bulky, doesn't necessarily have to have mobility because it tends to have a broad base, so it may not be whipping around as much. The term oscillation is used to describe these masses, and that basically means it can move independent to the cardiac cycle. So it's not a one-to-one, valve opens, mass moves, valve closed, mass moves. It's not in unison with the valve motion necessarily, or the cardiac motion. It can wiggle all by itself within the blood field. So that oscillation is a feature of a vegetation. So complications is where it gets interesting. The common complications really are, in addition to the growth of the mass, and the mass by itself generally is not hemodynamically significant. Occasionally it can contribute to an already stenotic valve, like a native aortic stenosis, that you then add a mass, the stenosis can get worse. Generally the mass isn't so large that it's going to cause significant valve dysfunction just by the mass effect. It tends to be local destruction that actually causes the pathology of the function. So this is an example of surgical tool down the ascending aorta, and then you follow a track that was evident, and it went from the aortic valve right into the right atrium. So an example of sort of an aortic RA fistula. And I'll show you a graphic at the end about sort of some of this local destruction. All right, so here's a case. If you look at this, you see a few things, and again, this is sort of what the teaching here is. It's not just about is there a mass or is there dysfunction, is does one explain the other? So if you look very closely, and I hope it projects up here at the base of the posterior leaflet, right up on the annulus, there's a little mobile element there. So it's not just calcification. Calcification, as you know, is very unusual to have mobility. Not impossible. There can be a mobile elements occasionally with sterile calcification. But there's some mobility on the base of the leaflet. And if you look closely on the base of the posterior leaflet addition, as it cycles through, it looks like there's a hole. And the question, is that real or not? Well, that's why we have color Doppler. You put the color on. So it's very important to recognize when you see MR or any valve dysfunction, is this occurring at the coaptation zone? You know, we've talked about this when we talk about MR. It's mechanism. Just, you know, focusing on the quantitation is not enough. You've got to say, why is it there? And this is very important to recognize. This is a posterior leaflet perforation. And in fact, through the middle of the valve at the coaptation point, there's no problem. So there's not even a pixel of coaptation MR. It's all perforation. All right. And I don't need my emails popping up. Okay. So there's the perforation. And this is a sort of, you know, very focal, right through the clear zone of the mid portion of the anterior mitral leaflet. That's the sort of destruction it can get. And this one is neat because it has a sort of heaped up function. This is what can happen. You get the Windsock deformity. Anybody who doesn't know what a windsock is, you just have to, you know, look outside when you're in an airplane and you're on the ground at the airport. Those things that are sort of showing, it basically looks like a sock and it shows which way the wind is blowing. But basically they're contained typically. So an aneurysm or a perforation often starts with a windsock. It's a weakening under flow conditions. It stretches and stretches, and then it like pops a hole through the toe. So that's typically what a windsock deformity is. So it's a long tunnel. Sometimes it can be a short tunnel, like in this particular image, and then a perforation through the end. All right, so it's a little further along. In this same patient, I like to slide because it's sort of the accumulation of every bad thing that can happen. So not just endocarditis within the heart, and endocarditis really means infection and inflammation of, you know, of an endothelial surface. So it doesn't necessarily, the carditis part sounds cardiac, but you can certainly have distal effects. So this case here has a penetrating ulcer, a vegetation, and a dissection flap, and a mycotic vegetation, sort of distal seeding of the infection. So what's different about prosthetic valve endocarditis? Well, one of the challenges we know, there's so many different heart valves out there. They all have different patterns of where the tissue is, where the flow is, different amounts of prosthetic material. There is nothing magical that we know of about TAVR, but thankfully the reported incidence of endocarditis of TAVR is still very low. Nobody's yet saying that it's better than a surgical valve, but you know, we've done at this site alone 1,000 TAVRs implanted and follow-up of probably 90% of those, and I can't think of a single case of endocarditis yet of a TAVR valve that we've confirmed. So there are case reports out there, but it's interesting. We don't seem to see a lot of TAVR endocarditis. Maybe because the flow profile is so good and the gradients are so low that destruction and that sort of chaos of flow isn't there. Don't know. That's right. That's right. You're not opening the chest, of course. You don't have all that whole exposure. So the early infection was usually a surgical issue, but we don't see that. So here's a case, and we often focus on prosthetic valve. So there's a prosthetic valve in the aortic position. I would say there's some lumpy bumpiness of the mitral valve, a little thickening. Even on my good resolution laptop, I don't see a defined mass on the mitral valve. There's maybe a suspect in the posterior leaflet. Kind of over here. Here's the prosthetic valve. And if you stop looking, you might be content. But if you keep looking, you see this gelatinous thing kind of quivering right over here in the ascending aorta. And that's not normal. And this is somebody who had ended up having persistently positive fungal cultures. So another example of fungus. And then when this patient went to the OR, what they found was that there was a tiny little stitch sitting in the ascending aorta from where they had done the aortotomy and sewed it up again. A little tiny piece of thread in the ascending aorta. And that was enough of a sort of an attachment point of a focus for the fungal ball to hold on to. So again, you need some endothelial disruption or abnormality even to get prosthetic valve endocarditis or prosthetic associated endocarditis. So this is from our lab. This is somebody who's had mitral valve repair, and they have a complete surgical ring. And you've got this thing here, and another one over here. So the question is this endocarditis?
We don't see a pointer.
You're not seeing a pointer? Well, I don't know why it's big. Okay. Yeah. Here it is here in the very middle. It's much bigger on my laptop. I don't know why it shrinks when it gets presented. But it is. Okay. These are like little Trump hands. They're small. Look at the Trump hand. So there's this stick here, and there's this little guy here. Oh yeah, it's all being recorded. All right, so what are these? So do these meet the criteria for endocarditis? Is this a vegetation? Anybody? Sutures. That's one suture? You're not on the wrong track. What it is a knot, right? So that's doing the. It's not mobile at all. So that's a good. So on the differential of is this a vegetation, mobility helps you lean the needle towards more confidence about vegetation. It's not at all mobile. It's pretty rigid. And if you know what the surgery is and what the sort of device was, this is an attuned surgical ring. It has like a big an ingrained suture around it. So one of these is actually sewing in the ring with a continuous suture all the way around. It only has one knot. So I don't know which is which, but one of these is sewing in the ring, and then when the surgeon, he throws like 10 knots and then builds up a little tree of knots, and that's what you're seeing. And the other one is the attuned ring, which is a ring, it's like a belt. After the annular ring is on, he can tighten this belt, and then he has to sew a bunch of knots to hold it in place. So these are just two trees of knots. But at other centers and at this lab, we've been sent, people who have repair, go for an echo, somebody sees a mass, sends it to us as endocarditis, patient feels phenomenal, culture negative, all the stuff, and you just say, no, that's what the surgeon did. So part of the issue is knowing what your surgeon does and what the surgeons look like, and that's why I encourage everybody, spend some time in the OR and see what they do. This is a different case. This is another example of somebody post-mitral valve surgery, has a complete ring, has a long linear strand. What do you think that is? Say it? Well, okay. So it's mobile, so it meets the wiggling criteria. It's mobile, it's very linear. There's no bulk to it at the bottom. It's kind of uniform. So it's bizarre. Again, what was the surgery? This is the ring, this is the suture, and somehow this was thankfully from another center. We think the surgeon just didn't know what they were supposed to do with this, and they cut one off and they left the other one. So the ring was sewn in, mismanaged belt, and now you have this long linear thing, which is a piece of prosthetic material. It's causing no harm, still there, but it confuses every echocardiographer who looks at this patient's studies forever. So that's just the point of prosthetic material is trying to differentiate and doing a little digging, finding out what happened, what's it supposed to look like. So we know the high-risk cardiac conditions. Of course, this was a large change to the endocarditis guidelines a few years ago. Any prosthetic material, and it doesn't matter how the prosthetic material gets there. So we have this comes up a lot. A mitral clip, a TAVR, they're not surgery. but they still are big risk factors for endocarditis in theory, so they count as full prosthetic valves. Rings, clips, anything that got in there. It doesn't matter if a catheter put it in there or a sternotomy got it there. Previous endocarditis, and then a select list of basically blue congenital diseases or unrepaired. But it's not older person, bad teeth with mitral valve prolapse or mitral stenosis or even native valve aortic regurgitation, although we still get these calls all the time. And people still want to prophylax them.
You know, Steve, it's interesting that in today's world, at least what we see here, you know, we don't see that often anymore. The clean patient who had their dental work and now completed endocarditis.
Yeah.
We see a lot of old folks that had infected knees. You know, and then now they come in with the aortic valve, usually aortic valve.
So
that's not even in the that's not even in the book. But you know, beware of these old people. You know that they're going for the knee replacements or things like that. They get a septic leak. Boy, they do have a higher risk.
That's exactly right. So I was going to talk about that. So historically, depending what reference you read, it used to be rheumatic native disease was the big risk for endocarditis. Nowadays, you're living longer, more people on dialysis, which is a immunocompromising state, more people who have some form of intervention, be it just pacer leads and all these other things. So absolutely right. Everybody has a much more complicated cardiac history who presents now. And beware of things like chronic low back pain, which can be a discitis and a disc abscess and seated, and that's kind of their recurrent stuff.
I guess a pacemaker fits in this for prophylaxis. The prosthetic
Yep.
material.
Yep, it does.
So if somebody had a pacemaker, they should get prophylaxis when they go to them.
I don't think I've seen anything different than that calls it out as different. So if you have pacemaker, and that probably gets missed a lot, I would say.
I suspect it is.
Yeah. Yep.
The other thing that's interesting, by the way, is that in these old folks, we rarely see endocarditis on a Mac unless it's a renal patient. So again, these old folks who get septic knees, they most frequently get the aortic valve, and they don't get mitral even though they may have Mac. I personally don't know why that is. Usually, if you have somebody with endocarditis and Mac, they have end-stage renal.
Yeah, the other thing is I'm curious in your experience. I don't think I've seen really hardly any, maybe one or two, of calcific degenerative aortic stenosis with endocarditis.
That's correct.
Tends to be bicuspid, not very stenotic, or regurgitant.
You're right.
But I don't know if it's the high flow state or something. It's just too high flow.
Folks who come in, they don't have AS either. They have, they have some sclerosis.
Yeah.
You're right. People who have actually bad AS.
Yeah.
I cannot remember the last time I saw
can't either. Yeah.
That's
So,
I think it's a very
so I haven't seen that, but maybe regurgitant lesions have a higher predilection than stenotic lesions with native valves. I'm not sure. Maybe we should look at that. Yeah, we don't see a lot of that, but you're right. So prosthetic valve, and this can be a real challenge. Is this a thrombus? You see a couple of different sites here, sort of prolapsing into the prosthesis and diastole, or is this a vegetation? Very hard to know, really hard to know. And the clinical approach is you treat both. You give anticoagulation, or this is a mechanical valve. Obviously, the anticoagulation should have been ideal to begin with. It may not have been. So that could be really hard, and we often heparinize and culture and try to figure it out. But it's very difficult to be confident, with the exceptions if you have a huge, bulky thrombus that sort of wraps around. That's unlikely.
So that's one clinical question. If in doubt, and you want to coagulate what you get blood cultures, is it dangerous to anticoagulate a vegetation?
I have not seen that, no.
So we cannot figure out how to No, I understand, but
I think the danger is if you're planning an intervention for the vegetation.
with a vegetation, be more likely to embolize the situation.
Yeah, I've never seen that. I've never seen that as a concern. No. The practical approach is we tend to, when you're unsure, you give them more anticoagulation. Yeah. So this is a clinical challenge because you're probably in this case, I don't recall exactly what happened, but typically it's dry anticoagulation. If they're frankly culture positive and behaving like endocarditis, that's a concern. It's going to be very challenging to convince surgeons to take out a normally functioning prosthesis. This is a slightly different case. That's a mechanical valve. This is a bioprosthetic valve. In this case, it did kind of follow the adage of large, bulky veggie on the flow surface, mostly. So, but it was really on both surfaces ultimately. So there's a lot of dysfunction, a huge mass. I don't recall exactly why this patient didn't go to surgery other than probably very little symptoms. And effectively, relatively normal valve function. But 6 weeks of IV antibiotics, which is often an approach to make him a better surgical candidate, not necessarily make, not do the surgery, but sometimes after 6 weeks of antibiotics, the bulk of the mass is gone. It looks good, although not completely normal. You can still see that some of these leaflets don't fully open normally. But the bulky stuff is gone. There is some paravalvular leak. So this is sort of one of the consequences of endocarditis, is not necessarily destruction of the leaflets, but any other annular tissue. So there's PVL here in this case, 3 discrete foci of paravalvular leak. And you can look, there's a little bit of stenosis. The leaflet doesn't quite open normally anymore. This patient actually did not go to surgery, did fine. Had 6 weeks of parenteral antibiotics and then was left on chronic oral suppressive antibiotics and managed to avoid surgery. But that's the exception. That doesn't usually happen. This one's interesting. This is actually recently a case through our lab. He had 75-year-old bioprosthetic AVR a couple of years prior. So really after 6 months, it sort of changes the antimicrobial landscape. Within 6 months, there's a certain list of sort of nosocomial or surgically acquired bugs. But after 6 months, you tend to think of them as just chronic. So he has this echo. It actually doesn't look too bad in this particular image. He did present with, obviously, clinical syndrome that was consistent with infection. So T, another image here. Now you see a little bulk here that is abnormal on a bioprosthetic valve. So he's clearly got a mass. You see it in both views. Again, doing relatively well, not a lot of enthusiasm for clinical reasons to take him to surgery for a small, relatively asymptomatic mass. It wasn't completely normal, and if you look at the Doppler gradients, he's got a velocity here over 4 meters. No real aortic insufficiency. I'll draw your attention to this little area up here, which is a little concerning, if you can see that. Look at Trump's hand. So there's a little lucency up here. So that's a little concerning. And then after 2 months of antibiotics, he goes for another one. The bulk is gone. Great news. He doesn't need surgery. But look up here. So now it looks a little bigger. Okay, so now we have a peri-aortic abscess. And that's really what they look like. So it's this evolving thing here. And this is where I explain, sort of gives you a sense of what that is. And that is not going to get better with antibiotics. That is surgery. There's no other option for that. And not necessarily an easy surgery. Once you debride the native valve, you have to debride all that out, and it can be a fairly creative event with patching and stuff. I guess it can be very difficult. So he did have to get a redo. This is another case, another example. This is a native valve where you can get that same sort of peri-aortic abscess, aortic root abscess. This is one that was left a little too long and a massive destruction. And you see the abscess actually tracked right down the anterior mitral leaflet and it's sort of destroyed up into here. And these things can be very extensive. They can actually sort of spiral up around the ascending aorta. And Dr. Reardon describes a case that he saw where a gentleman came into the ER with a pulsating mass in his upper sternum. And the ER doc wanted to put a needle in it. And he came in straight to the OR, and it was basically an abscess that sort of candy-caned all the way up his aorta and was bulging up here. So they can be very impressive. This is sort of the classic, and this is sort of typical. It's not necessarily all the same. It's a little heterogeneous in terms of the density. But a little bit about the natural history. So you start with an abscess. As soon as it ruptures on one side, it's no longer contained, so technically it's no longer an abscess. Abscess means contained. So once it becomes pulsatile, that means flow's getting in. So the pus is out, blood is in. That's not necessarily a better scenario, but that pulsatility is important. So this is a pseudoaneurysm now, because you have a rupture. It's not a discrete 3-layer aneurysm, it's a pseudoaneurysm. Then you can actually see the flow go in and out. You can Doppler it, convince yourself, but the color is pretty clear. So that's a rupture on the LVOT side, and that kind of rupture can continue. You can rupture on the LVOT, and then you can rupture back into the aorta, and that's now a fistula. So you actually have a bypass around either a native valve or a prosthetic valve. So that's the terminology distinction between pseudoaneurysm, abscess, and fistula. There can be a natural history. So the point of this is that, it's not just the valve structures, it's this entire cardiac crux. So the concept is that the fibrous skeleton, all the tissues that are connecting the valves, depending on the bug, particularly Staph aureus, can be destructed in any number of ways by aggressive endocarditis. So you really have to be thinking about unusual connections. Fistula between the LV and the RA. Okay, that can happen. High septal to the RA, that's a fistula that can happen. Aortic root to either atria, that can certainly happen. Just simple VSDs can happen. So these are things on a color Doppler evaluation you have to be looking for. And this is sort of just understanding the top-down view. This is the left fibrous trigone here, the right fibrous trigone. There's conduction tissue that runs right through here. So it's not uncommon, as we know, to have conduction delay and heart block with extensive endocarditis because it actually takes out the conduction tissue right here. So just be thinking about the anatomy outside of just where the valve leaflets are. It's all the tissues that connect the valves can be very much destructed. And that's just a view looking down on an aortic valve, mitral valve and aortic valve, from above and from below. All right, so basically we get these text messages every once in a while. Patient X is going for some procedure. What do you give them? I probably look this up twice a year because I always forget it. But it exists, and Google is very good at giving you those answers quickly. But basically, it tends to be, basically amoxil, 2 grams of amoxil, 30 to 60 minutes before procedure, unless they're allergic. So I'll summarize endocarditis quickly, and then I have a couple other slides I want to show you. So it's inflammation of the endocardium. It involves the valves typically, but doesn't have to be exclusive to the valves. Any prosthetic material can be involved. The prototypic lesion is a vegetation, which is a mass of platelets and fibrin, and usually with oscillating motion, but things like fungus can not behave that way, and obviously echo. I think my title was role of CT and MRI. There's basically no role for MRI. CT is good for finding funky things outside the valves, like tracks, connections to things, and whenever there's prosthetic material involved, then CT is really very valuable for sort of surgical planning. But for the diagnosis, it tends not to have the temporal resolution to help you differentiate mass from thrombus. Thrombus from endocarditis, and likewise MRI, though it can do tissue characterization, not from a wiggling, oscillating mass. It really can't do it. Any questions about endocarditis or comments? All right, then I want to change gears real quick and do something a la carte. I want to show you a few slides that I presented at ASC last week. It's a short little talk. I thought I'd just give you an update on TMVR because it's something that we're very much involved in. And it was a point of confusion, some of the terminology. All right, so transcatheter mitral valve replacement is a term for TMVR. Mitral valve is much, much more complicated because of all the subvalvular apparatus, the pressure gradients, the dynamic motion. All of these things make it relatively more complicated than the aortic valve. So from an engineering perspective, if the aortic valve receiving a TAVR is akin to a plastic 3-wheeler, this is sort of where we are with a MitraClip, or any sort of mitral intervention, rather, TMVR. So there's confusion because the term TMVR is used for a lot of things, and people mean different things by it. So it encompasses kind of all of this to some people. So a valve in a prosthetic valve, so a transcatheter valve implanted into a previously present prosthetic valve, some people call TMVR. A valve implanted into a surgical ring, some people call TMVR. Most people, what they mean is valve inside a native valve. So I'll just give you a quick example of each of those. So valve in valve, 46-year-old, end-stage renal for a long time, hemodialysis. He'd had a bioprosthetic valve because of social reasons and basically fear that he could not take oral anticoagulation appropriately. And presents with severe prosthetic valve stenosis, intubated in our CCU for a couple of weeks and no basically surgical option. This was his echo. See lots of smoke in the LA. On 3D, you don't see any opening of the device at all. Yeah, how can he be alive was exactly the question that we asked. But the flow reveals there is some flow. So we have a few RBCs squeaking through. Sort of a generous diastolic flow area of about 1.1, so clearly severe. Mean gradient of 18. So when we first started doing this, it was a transapical approach. Now, in the last probably year, we now have transitioned to transeptal approach. And then sort of one slide, this is basically what the procedure looks like. Before, transeptal deployment, typically of a sapien inside the device, and then a final result. And then even though you have the concentric valve inside a valve, the flow gradients or the flow parameters can be excellent. So this is now a sapien inside a bioprosthetic valve, 2.3 centimeter flow area and a mean gradient of 3.
How do you size them, by CT?
Typically by CT, yeah. Yeah, and actually it's a good point. The surgical ring sizing is useless. I mean, it gives you a ballpark, but if you have a 23 ring or a 25 ring, it doesn't mean that the diameter is 23. You really have to do a CT measurement. Yep.
It's actually always larger. It's the sewing ring, that's what the measurements of the prosthetic valve. So at least about 3-4 times 5 millimeter difference between the outside and the inside.
CT base. This is a tougher one. This is a gentleman who had just had a band. So a band or a partial ring or synonymous. Some surgeons believe you don't need to support the anterior part of the mitral annulus. So this is somebody who at another center had a bypass and a mitral repair using a band. Years later, he presents with prolapse of his anterior leaflet, severe MR. The discussion then was, we actually discussed some MitraClip for these patients, but he'd had quadrangular resection and chunks of his posterior leaflet taken away, so nothing really left to clip. So his only option was redo surgery. He was very high risk, or a transcatheter procedure to stick a new valve inside the band. That just shows the anterior leaflet. There we go. So that was the discussion. There really wasn't any visible posterior leaflet to clip. A lot of calcification here of a subvalvular apparatus, but his LVOT looked pretty open. But we knew that the anterior mitral leaflet was long and calcified, so there was some concern for his LVOT to put a new valve and jam it in there, because what it does is it displaces the anterior leaflet closer to the LVOT. So immobile posterior leaflet, not a clip candidate, calcified chordae. So the procedure was done transeptal. This is a sapien, so the same valve that we use for the aortic position. Now we'll just turn it upside down and stick it in the mitral. Immediately, this balloon expanded. Immediately afterwards, there was some PVL. See here on 3D. The valve diastolic function was good, systolic function was good, but the question is that amount of PVL a risk for hemolysis? We don't have any interprocedural way to answer that question. We don't know. So sometimes a very small leak could give you profound refractory hemolytic anemia. So whenever possible, we try to get rid of it. So that's what happened. We re-ballooned the valve after its balloon expansion. So there's a transeptal balloon going in, ballooning it. It was a good result. The PVL was gone with a little more expansion. This is the post-procedure, immediately post-procedure. Here's the device. You do see the anterior leaflet, as expected, was pushed into the LVOT. There is now a color flow acceleration. And by Doppler, we get a little gradient, a peak resting gradient of about 20 millimeters mercury. So a small LVOT obstruction at the moment, but patient was thought to do well. Then the next day, as we usually do, we do a transthoracic study. Oh, I'm sorry, this is the sort of final. We started here, went to here. That's just the before and after. And then the next day is transthoracic. It's interesting because now he has this mobile mass here in his LVOT and another mobile mass here hanging off his pat muscle. So in 24 hours, it's pretty hard to get endocarditis with a mass that big. So it's not endocarditis. Very unusual spot to get a thrombus because the LVOT is very high flow. So it's like, asking a piece of paper to just float in the middle of white water. It's not going to do that. It's going to get swept away. So very likely what we determined with this is very likely a presumed ruptured cord following the valve and band procedure, because we knew there was a bunch of calcified chordae in that subvalvular apparatus. So one cord ruptured after the new device was forced into the LVOT. Didn't have any really hemodynamic consequence, at least at this point. LVOT gradients didn't change, ventricular function didn't noticeably change. But there's a little, long-term, there's some concern that you disrupt that annular ventricular coupling. The PAP muscle has to pull on something when it contracts, and it's the mitral annulus. And the more cords you break, the more you disrupt that function. So that's a little complication. So that's something we consider now when we're trying to evaluate TMVR, which is valve in band or valve in ring versus MitraClip.
Interesting, was
Yep.
the echo texture is quite different. Did you have that before?
The calcification?
Yeah, but
They were there on the preceding ones, but obviously they weren't mobile because they were rigid, they were attached to each other. So it's the mobility that sort of catches your eye, and that's because they ruptured bits. So I think it was a strut cord to the mid-anterior leaflet that just broke on both sides. So you're seeing both halves of it moving within the transthoracic. We haven't gone back and done a TE since, because he's clinically doing fine, but that's sort of in the mindset of LVOT.
CT, probably post-procedure CT, together pre-procedure CT.
Had a pre-procedure CT. I don't think he's had a post-procedure.
For the PAP muscle, he seemed very well.
You would. I mean, clinically, he's doing so well that we haven't chased this. It's presumed at the moment, I guess. At some point, we might do a CT, but it'd be probably academic purposes only at this point. Yeah. All right, so in the last couple of minutes, I'll just show you the valve in native valve, which is what probably most of us mean by TMVR, but not all of us, which is why I showed you the other cases. So these are the devices. This is a partial list of the devices. There are, none of them are on the market, but all of them are being evaluated in some capacity in research trials. So some will make it to market, some have already died. This is a Tiara device out of Vancouver. It's designed with a D-shaped sort of anterior, so it has to go in a certain way. You have to line up the anterior leaflet with the posterior leaflet, so the orientation is very important, which is all echo-driven. It has these large little tabs that reach up underneath the valve, and two of them sit on the trigones from the ventricular side, and one sits on the posterior shelf. So it sort of anchors itself like a stool, has 3 legs, sits up against the mitral annulus. The challenge with all these devices, if you think about the hemodynamics, these devices have to hold back LV systolic pressure, 140. TAVR devices have to hold back aortic diastolic pressure, which is 70. So it's at least, on an average, double the pressure gradient that these devices have to hold back. They're larger, so they act like sails, so they're covering a bigger area. So engineering-wise, it's harder. It's a bigger device. It's subject to more surface area for pressure. It's at least twice the systolic pressure. And depending on the patient you're putting it in, the annulus is dynamic. So not so much on a functional case, but very dynamic on a prolapse case. So they all sort of approach anchoring differently. This is a little recent review that came out. The Tendyne one is a transapical delivered. So you've gone through the apex, it drops a little anchor here, and it tethers the valve. So what keeps it from being ejected into the LA is this tether. This is one here. This is the Neovasc one. It has this sort of, it depends how you put it in. It has an anterior, posterior, and those tines I just described for you. This is a cardiac cue. It has these 12 equally spaced things that sort of crimp up the leaflets from below and scrunch up all the cords. It's a total circle, so it doesn't matter how you put it in. There's no front and back. It's sort of agnostic to position is the term they use. This is probably the one that I'll just point out to you. This is most similar. It's not called it, but it's most similar to the Medtronic Intrepid valve, which is the one we are implanting. It's got a whole bunch of different ways to anchor itself. It's kind of shaped like a champagne cork, so as it gets pushed towards the annulus, it sort of wedges itself in there, and it's got a bunch of little sharp tines that help hold it in place, and it's self-expanding nitinol, which pushes out. So it's got radial force, tines, and a cork shape to hold it there. So the main differentiating feature of all these devices is how are they holding themselves in place. Don't read this. It's just a list of all of the features that we measure off a CT before we do these procedures. I mean, there's like 10 things just describing mitral annulus. And this is all about patient selection, because the engineering is so challenging. The patient selection issues are things like what's the distance between the trigones, what's the AP distance. One of the most important concepts is the LVOT, for the reasons I've just shown you in that prior case. You're taking a large, typically anterior leaflet, you're displacing it into the LVOT, and you're putting a big device there, which is actually going to extend the length of the LVOT. So there's now this concept of a neo-LVOT, the new one you've made. And that's a big challenge. And one of the big issues is the aortic mitral angle. This angle between the aorta and the mitral valve, the perfect scenario is they're 180. You'll never obstruct it. The worst scenario is they're 90 degrees. Anything you do here is going to obstruct this one. And then most patients are somewhere in between. And we try to figure out what's the aortic mitral angle that won't create LVOT obstruction. So I'll just show you some images from, I think this was our first or second. This is our first TMVR case. An elderly gentleman with severe functional MR. You don't need the color. The mitral valve never closes. Importantly, it's open at the same time as the aortic valve. So he had severe functional MR. This was the planning. So based on CT, and this is the device. So you see these tiny little tines and this kind of cork shape. And the thinking is, this is its position, and this is an overlay. So this is a CT in diastole, kind of a cartoon really of the valve, and put it on there. You're not interacting with the image, but you're just an overlay. So it's sort of a first pass of sizing. And that's the diastolic frame. There's the systolic frame to the right, and you can see the LVOT here. This is sort of the sizing. This was a 46 millimeter device based on a 25 millimeter or 25% oversizing. So you never right size them. You have to oversize them so that they have consistent pushing out, right? If they were right sized, they would just fall out. So they have to always be pushing out to stay there, and that's the oversizing component. And then this is the LVOT image. So these basically two frames, the blue and the red. The blue is up here, so this is in diastole. This is what the LVOT projected area would be, and it's about 4.5 centimeters. And in systole, at end systole, the red here, the maximum LVOT area is about 1.8. And what's acceptable, we don't know. We know in the TAVR world, an effective orifice area is about 1.7, 1.8. So this would be acceptable valve area on a TAVR. One of the things that's come, the recognition is the area at the end of systole isn't as important because you've already done all your ejecting at that point. It really is the area, what's the average area throughout systole when you have to be doing the ejecting. So these are some of the technical challenges that people are trying to figure out is modeling the size of the outflow tract. So this is the procedure. It's done in the hybrid OR, still done via transapical. So it's a beating heart procedure, no bypass, no cardiopulmonary bypass. Small surgical incision. The incision is actually fairly small, but then they put a big thing around it to kind of stretch it out. So the actual incision is small. It looks bigger once they stretch it out a little bit. And then this is like a 32 French, which is basically a garden hose through the apex. It's huge, far too big to go transfemorally so far. But that's what everybody's working on, is miniaturizing this enough to do it transeptal. One company so far has done humans transeptally. All the other ones are trying to catch up. So the echo, one of the first things to do is to guide the apical finger poke. So the surgeon has to know they see the hard apex, but they don't know where they should actually poke through. So that's a rule for echo. How you like that, huh? So the difference in the OR, they wear gloves. So it doesn't quite look like that. But you see this little poke, and you actually are guiding them, saying, the true apex is actually very, very thin. It's a millimeter or two thick. And you don't want to go to the true apex, because then when you try to seal it up, it'll leak. So they actually go through, not the true apex, but just off from the apex, aligned to get a straight shot through the mitral valve. And then this is this device has been already up into the LA. It's self-expanding nitinol, so you just let it open up, and it opens like a flower. And you orient it within the LA, and then you slowly bring it down to the mitral annulus, leaving about 8 millimeters, as you can see here. This is a little ridge here, so you have to landmark everything. Then what you do is you rapid pace, turn on the pacemaker to create cardiac standstill, and bring the valve down for that final 8 millimeters and land it. And at the time, everybody's asking the echo person, how does it look, how does it look, how does it look? Is it in the right spot? The problem is the device obstructs all your landmarks. As it comes down, you can't see any of the landmarks that you just landmarked it with, and then they want to know that it's in the right spot. So it's not a fun moment, but overall it's a fun procedure. And this is what it looks like after it's in. So fully functioning, LVOT is fine in this particular case. Everything looked good. And that's kind of
So Steve, I'm confused one thing. The annulus is dynamic. So the annulus, so do you fix the annulus?
The annulus doesn't stay dynamic this way, it stays dynamic this way. So you preserve the annular descent, but not the folding.
But you make the circumferential change of the annulus gets lost.
It's fixed.
You fix it.
For this device.
Yeah.
The other device, some of the devices actually have an annular folding that they try to maintain. This particular device, it fixes it.
Can you go back to the previous? Is there a space between the LVOT and the valve there? Or
This?
is that-
Or here?
Up, no, below, just on the left, on your left.
That.
Yeah, yes.
That there. That's a good point. So that's, I'll show you on the other slide. The 3D shows it. It has this groove all the way around. So this device actually is a frame within a frame. So there's one frame, nitinol, that actually makes all the annular contact. And it's the one that gets beat up and moved and has to conform. This particular design is, then there's another frame inside, a completely circle. So no matter what happened on the outside, this valve is going to maintain its circle. But it has a little trough all the way around the outside. And what's supposed to happen is over the next few weeks, that trough fills in with clot and tissue and, yeah, so it basically controlled fibrosis. And they've got animal studies that at 3 months, it's completely flat now. So that trough is there as a cushion between the two devices, as you will, but then it fills in. Yep. In this case, looked good. There was no PVL and a tiny bit of central. Absolutely. Yeah. So that's one of the technology challenges is how long do you anticoagulate for? You do anticoagulate, but you want some controlled coagulation to fill that stuff in. And most of the devices have something like that. There's some way to insulate all that annular motion from the device so that it keeps working properly. This is interesting because this is the CT. So Dr. Q, this goes to your point. This was the pre-procedural CT. So note, get a rough sense of the EF and the annular descent. And then this is a CT post-implant. So the annular motion is reduced, but there's still a descent. But the ventricular contraction looks quite different. And this is probably a more elaborate version of what we see on every mitral clip, is that you create a competent mitral valve and you reveal the true ventricular function. So there's been no surgery, there's been no ischemia, there's been no, other than the apical insult of the garden hose. So that's what we're seeing quite a lot is there's an acute EF reduction. In the mitral clip literature, even chronically, it's reported to be about a 5 percentage point drop in the EF. It's more than that acute, and then it shakes out to be about 5% months later.
Part of the reason is you may be left with moderate mitral regurgitation.
Excuse me?
Yes, you're excused.
Yes, I know. I've read that at other centers.
And there's annular motion too. I mean, the annular motion is important.
Yeah, well, that's important for the whole ventricular function. You've got to compress this way as well as this way, so for sure. So just to, I wanted to just give you these couple of slides and talk about TMVR because we're doing more and more discussion around that. We now have multiple ways. With the sonographers, there's some confusion about post-TMVR, so it's better to use valve and ring, valve and band, valve and valve, or valve and native valve, which is this one. And that's just a nice before and after, and you see that little trough that has to fill in over time. So Maria is working, I showed you this before, just to do some modeling. We're doing some 3D printing of patient-specific CT data, trying to figure out really for our TMVR patients, these ones, can we better predict any LVOT problems using patient-specific anatomy. So last slide, challenges. The complex and variable anatomy, not just between patients, but between etiologies of MR, functional and organic, or myxomatous MR can be very different in terms of the engineering required. Maintaining the dynamic leaflet motion, particularly as it pertains to the LVOT. The anchoring is a huge challenge, and if your ventricle is very big, or your pressures are very high or very low, that can change the details around the anchoring. The sealing, I didn't really show you the cases of paravalvular leak, but even we've seen paravalvular leak. That sealing is very important, as you can imagine. Everybody's trying to get transapical, but so far the devices are so big and bulky that's not happening uniformly yet. And then thrombogenicity we just talked about. So I'll stop there. That's it.